It is estimated that 450,000 medication errors occur annually, leading to costs between $3.5 billion and $29 billion each year for hospitals. Medication errors not only impact outcomes financially, but may also lead to patient dissatisfaction, adverse patient outcomes, and death. Gleiger and colleagues estimated medication errors cause approximately 7,000 preventable deaths in the United States each year. Patient is a 68-year-old male who was admitted to the ICU for clinical observation after a surgical procedure. The patient is on heparin drip as an anticoagulant and ketamine fentanyl to provide analgesia and sedation. The incident occurred during the 11 to 7 shift. The RN involved was relatively novice, an RN Versant. The USC Keck Hospital has an RN residency program called Versant. It is an evidence-based, comprehensive educational and training residency designed to transition newly graduated nurses from student to safe, confident, and competent professional practitioners. It is a paced learning experience that allows the novice nurse to progress toward competent performance at the bedside. Going back to the specifics of the incident, there's a hospital protocol on the unit to change all infusions every 24 hours at a certain time or shift. Around that time, the heparin drip for the patient was due to be replaced. The timeline of the incident is as follows. At around 5 o'clock in the morning onto the shift, the RN brought the ketamine fentanyl inside the patient's room, thinking it was heparin, and checked the time of administration against the EMR. The computers are inside each patient's room. Since heparin is a high alert medication, a second nurse has to initial on the EMR, and this was done by a traveling RN at that same time. The wrong medication was given to the patient, ketamine fentanyl instead of the heparin drip, while the previous ketamine fentanyl is still infusing. As a result, 2 ketamine fentanyl infusions are running at the same time. The mistake was not discovered until the bedside endorsements done at 6:30 in the morning during the change of shift report. The AM and NOC charged nurses pointed out the discrepancy in the medications being infused on the patient during the rounds. The MDs were made aware and protocols were initiated for medication error incidents as appropriate, the SRM report, disciplinary actions, etc. The patient was monitored according to protocol and as ordered. The patient did not suffer from any long-term effects of the inadvertent medication error as noted during that time. No harm was resulted from the incident. The patient was discharged from the facility as planned. Investigation and interviews were conducted with the RNs involved, the 11 to 7 RN, the traveling nurse, and the charge RN. A fishbone diagram was constructed to determine or examine the causal factors from various categories, such as the environment, equipment, leadership, patient, staff, and procedures, after which specific action plans and recommendations were conceptualized as appropriate to the incident. Examining the environmental factors, according to the primary RN, he was distracted from the presence of family members during the time of the medication administration. Interruptions are defined as an event that occurred in the surrounding area that averted the nurse's concentration away from the primary focus of safely administering the medication. In a study conducted by Harder and Mark in 2013, it was concluded that addressing the patient's family needs is also a factor leading to greater incidence of error. For the equipment factors, a double independent check for medication is not in place. Barcode scanning and smart pumps are currently not integrated into the EMR. On the leadership aspect, the equipment needs not being met may be rooted to budget constraint. According to Wu and colleagues, the acuity of patients managed in a specialized unit such as an IC, more complex medication administration, and frequent need to use high-alert medications are key factors behind high ICU medication error rate. Possible causal factors relating to staff identified in the analysis include the novice or traveling nurses working on highly specialized areas such as the ICU, a factor of human error, and inadequate verbal communication related to medication verification process that may be caused by a lacking sense of keen judgment or critical thinking skills. The policies and procedures set for medication administration were not followed during the process, which may have been originated from a lack of familiarity or recall of this guideline.
The findings of the incident included the following. The RN who administered the medication did not follow the 8 rights of medication administration as specified in the policy number CP4156, Administration of Intravenous Medications, which states, before administration of any drug, the licensed practitioner should review the 8 rights: right patient, right drug, right dose, right route, right time, right reason, and right response. Referencing the Joint Commission National Patient Safety Goals 2014 for hospitals, the first goal specifies that patients must be identified correctly. NPSG.01 use at least 2 ways to identify patients. For example, use the patient's name and date of birth. This is done to make sure that each patient gets the correct medicine and treatment. Another is that apparently the label of the medication was not checked against the EMAR by both RNs, leading the primary RN to mistakenly hang the bag of ketamine fentanyl instead of the heparin drip. Conversely, the primary RN correctly signed the heparin drip on the EMAR as the due medication during that time. This is specifically highlighted. Policy number CP4117, Medication Safety Policies for High-Risk, High-Alert Medications. Medication defining heparin as a high-alert medication with specific safety policies whenever a nurse prepares individual doses of heparin for IV administration. A second nurse must double-check accuracy of dose preparation. For heparin infusions, a second nurse verification that the correct product is selected, the correct concentration, and the correct dosage. A second nurse verification is needed each time a new bag is hung, and all verifications will be performed at the bedside and in a verbal manner. Any interruption in the verification process will require starting over the verification process. In addition, the primary and traveling RNs missed to check the old IV bag that is being replaced against the new IV medicine before starting the new infusion. This is a deviation from the current policy on administration of medication policy, which states that the clinical staff shall read the medication label 3 times during administration and verify that the medication selected matches the medication order and product label when picking up the medication, prior to administration, and just after administration. Focusing on the National Patient Safety Goals for hospitals, specifically National Patient Safety Goal number 3, which is to improve the safety of using medications. It highlights the importance of verification for all medication or solution labels, both verbally and visually. Verification is done by 2 individuals qualified to participate in the procedure whenever the person preparing the medication or solution is not the person who will be administering it. For patients taking blood thinners such as heparin, specific goals are also situated as in NPSG.03.05.01. Take extra care with patients who take medicines to thin their blood.
Some of the positive features and good practice in place for the hospital are as follows. 1. Bedside reporting and handoff communication policies between incoming and outgoing primary nurse and charge nurse are clearly delineated. 2. Good policies and procedures and safety guidelines are in place. 3. Appropriate staffing and nurse-patient ratio. 4. Protocol for reporting medication errors. And 5. Timely investigation and immediate action plan implementation as appropriate.
For the action plan on environmental factors, it is recommended to establish a protocol plan utilizing noticeable garments, for example, sash, aprons, or vest, based on the need to improve safety during medication administration, supported by findings from a review of literature after the implementation of the intervention. The responsible party would include the administration, unit managers, educators, charge and staff nurses. The methods employed are policy, audit, Education, Observation, and Implementation. Freeman and colleagues in 2013 discussed and listed down the implementation of a bundle of interventions which highlighted the utilization of noticeable garments such as sash, pins, or vest, indicating a no interruption zone for the nurse while performing critical procedures such as medication administration. In another research entitled The White Vest Study, the nurses in 4 hospitals under study were observed before and after the implementation of wearing a white vest during the medication administration in the morning shift. It was illustrated that the overall number of interruptions during the medication administration declined. In another study by Pham and colleagues, one of the key findings is that errors were most likely to occur during the administration phase of the medication process at 36%. This underscores the significance of efforts centered on minimizing the distractions and workload burden during the medication administration phase.
For the equipment factors, since a double independent check system is not in place, it is recommended that the integration of the health information technology be implemented into practice, which includes the implementation of the barcode systems and smart pumps incorporated with the EMR for enhanced patient identification and safety in the clinical practice. The responsible party is the hospital administration. Methods include policy, audit, observation, and implementation. The Joint Commission emphasizes the importance of health information technology as it supports the clinical processes by accurately storing, displaying, and sharing critical clinical information among all healthcare providers, even to the patient. In an experimental study performed by Poon and colleagues in 2010, there was a 41.4% relative reduction in errors from 14,041 medication administrations in an academic medical center implementing barcode scanning for medication administration. In another observational study done in 2013 by Bonkowski and colleagues, implementing BCMA in the ED was associated with significant reductions in the medication administration error rate and specifically wrong dose errors. BCMA was associated with a reduction in the medication administration error rate to 1.2%, a relative rate reduction of 80.7% for almost 2,000 medication administrations observed during the study. Moreover, in a controlled trial of smart infusion pumps to improve medication safety in critically ill patients by Rothschild and colleagues, it was concluded that intravenous medication errors and adverse drug events were frequent but could be detected using smart pumps.
On the issue of patient acuity, it is recommended to reinforce ongoing assessment of patient acuity and staff skill, set as appropriate, and set emphasis on the implementation of policies and guidelines in place concerning medication administration and management of high alert medications, especially for critically ill patients. The responsible party include the unit administration, which are the nurse directors, managers, and educators. This can be done by means of education. A systematic review of interventions to decrease medication errors in intensive care units revealed that the emphasis on protocols and guidelines and various modes of education for the staff, that is, simulation-based trainings compared to didactic lectures, significantly demonstrated reduced medication errors post-intervention.
The action plans for staffing include mandatory skills fair and competency exams with emphasis on hospital policy, procedures, and guidelines on medication administration, teamwork training for the nursing staff with an emphasis on facilitating channels of communication to benefit the practice of the nursing profession. The responsible party include the unit administration, the nurse directors, managers, educators, charge, and staff nurses. In a study conducted by Westbrook and colleagues, it was deduced that the intravenous administrations have a higher risk and severity of error than other medication administrations. A significant proportion of errors suggests skill and knowledge deficiencies, with errors and severity reducing as clinical experience increases. A proportion of errors are also associated with routine violations, which are likely to be learned workplace behaviors. which necessitates further reinforcement and emphasis by staff education and skills competency training. According to Wilkinson in 2013, in these processes, the clinical nurse educator assists registered nurses through education and collaborate with nurse managers to evaluate the continuing competency of the registered nurses to perform in their required duties and not be complacent with their skill. FAM and colleagues highlighted teamwork and safety culture as an important aspect in minimizing medication errors and adverse events in healthcare practice. Furthermore, a study performed by Jones and colleagues on creating a culture of safety in a workplace environment revealed that training on teamwork skills can lead to a positive improvement of staff perception related to a culture of safety among emergency department staff. Ultimately, it was identified that communication failure is frequently the root cause of medication errors, delays in treatment, and wrong-side surgery, leading to an estimated 200,000 deaths annually in the United States.
For procedural factors, our recommendation is to develop a teaching plan emphasizing the significance of policies, procedures, guidelines for promoting safety in the practice. The responsible party include the unit administration, nurse directors, managers, and educators, and the charge and staff nurses. Literature suggests that policies and procedures in place enhance the safety in processes involving procedures in the hospital, such as medication administration. In a cross-sectional study of emergency department medication errors conducted by FAM and colleagues in 2011, it was concluded that the most likely cause of medication error is not following proper procedure or protocol, necessitating measures to strengthen these through orientation, in-service activities, using instructional methods that are easy to comprehend.
Overall, safety in the professional practice of healthcare must be employed at all times. Medication errors are one of the preventable adverse events.
It has been long established that these types of adverse drug events are costly and dangerous.
Through collaboration, teamwork, and evidence-based practice, these challenges may be managed with the goals of safety achieved.